Hey everyone, thanks for taking some time to review the staff meeting for the second quarter of 2025. Before we jump in, please make sure that you comment your full name on this video so that you can receive credit for participating in this staff meeting. If you're unable to comment on the video, please make sure to reach out to me via my work email at caleb.fulkerson@nortonhealthcare.org just to let me know that you have watched the staff meeting. As always, let's start out the meeting with some wins. First of all, welcome to our new staff, Haley Yates, Alexis Mullins, and Tiana Miles. You all obviously know these friends by now, but there are three of our new PCAs on 7 East. Alexis isn't new, but we're happy to have her back home on 7 East. A huge win for 7 East PCU is that our unit-based council is back up and running and has a very bright future in the highly capable hands of Brooke Byrne and Hope Antkees. Keep in mind that our UBC meetings are now occurring on the second Wednesday of every month, so please go ahead and mark your calendars, and then the links for the meetings are going to be sent out each month through GroupMe or Facebook. We still need a lot more volunteers to represent our unit on various hospital committees, so please reach out to Hope or Brooke if you have interest in getting more involved in CH. Not only would it greatly benefit our unit and the hospital, but it also looks great on a resume. Another huge win for 7 East PCU is that Kayla Brazo is our new co-chair, along with Lauren Dybel. This summer, R&R is going to be hanging a giant coloring sheet on the unit. And then also, please continue to vote for Employee of the Month. And perhaps the biggest win for 7 East PCU that I can think of is so many daisies. We had 11 nominations in April alone and multiple more in May. So congratulations to Brooke, Emily Berry, Brianna, Emily Whitaker, Haley Knight, Abby, Brooklyn, Sophie, Samari, Demi, Erica, Caroline, Philip, Jasmine, and Brianna. And then I'm probably also forgetting a few, but we had so many Daisy nominations. We obviously think you all are amazing, and it's wonderful to know that our families think so too. A few updates, NCH updates. By now, I hope that you all know about the Jocelyn Insight app. If you haven't downloaded it yet, please do that now. This app is the most direct line to your executive leaders, like Eric Martin, your chief nursing officer, to share your voice about the change that you want to see at NCH. Here are some QR codes that you can go ahead and download that now. The Resident Nurse Collaborative, it's a new group composed of residents and nurses, along with resident and nurse leadership, with the aim of improving resident and nurse collaboration. Help us foster community and support between nursing staff and residents so that we can improve the work environment and patient care. That's their ask of us. They are also asking that we fill out this anonymous survey to help them better understand what's important to us so that they can better direct their efforts to foster a collaborative environment between nursing staff and doctors. The QR code for this resident nurse collaborative needs assessment is right here on the screen. A few FYIs. As we are admitting our patients, please make sure that we're completing the EPIC travel screening in the admission navigator. Specifically, make sure that you're asking about domestic travel as well as international travel. So if they've traveled domestically or internationally, please ask for the location of where they've traveled and then type it in. The location you type in can alert you to potential risks for exposure to diseases such as monkeypox. Please make sure that we are using the callback feature on the Voceras when possible. So when your patient calls out, don't just decline the call and push it off to the ancillary, especially if we don't have a PCA and we have a mobile secretary. Use that middle callback button, and then you can talk directly back to your patients in the room when they call. Telemetry. Make sure that when we put patients on telemetry that we call the monitor room to let them know, and also to make sure that we are logged into Vocera for that room so that the monitor tech can reach you with concerns about your patient, any telemetry changes. Also, FYI, patients who are in hold areas can be placed on telemetry now through the same process. If you are interested in getting your BSN, the Norton Healthcare Scholars Program is here to support you. Registered nurses employed at Norton Healthcare who have an associate's degree in nursing can join a 1 month program in partnership with Indiana University Southeast. The deadline is Monday, June 30th. And then interested applicants were encouraged to request a career coaching appointment by May 31st. But you can still request that career coaching appointment. Just go ahead and apply. The deadline again is June 30th if you're interested. There is a new row that displays patient preference on the MAR. So this is going to allow you to chart the patient preference for medication prescribed for lower pain scale. So this is permitted where orders already exist for that medication with the PRN indication of pain. If the patient requests lower dose medication than prescribed, you can select yes. As a reminder, it's not permitted for a patient's preference to allow use of a higher level of pain medication. The documentation of the patient preference should occur at the time of administration to help clarify the difference between the recorded pain score and the ordered medication. And then if additional medications are needed, an updated provider order is required for that. A quick clarification about charting fracture prevention. So if your patient is non-ambulatory for any reason, so they would score a 6 in this section. So for example, a 3-month-old patient cannot reposition themselves or walk, obviously, they would score a 6 in this category. Quick reminder about the EKG checkoff process. Once the EKG is ordered for your patient, the nurse is going to call the PCA to do it. And if the PCA has been checked off, they'll go ahead and perform that EKG. If they have not been checked off, then they will then be, as the PCA, be responsible to delegate the task to either another fully trained PCA or last resort, call the RT on the floor. And then RT will deal with that EKG as a last resort. There is now a new measles diagnosis panel. So the new panel includes the airborne isolation order, which is required when ordering this panel. And if you remove any order from the panel, it'll cancel the whole panel. The current standalone measles PCR order is going to be removed, also because it's now in this part of this new panel. There is also a new Blood Ready icon on your Epic storyboard that went live in May that you may have noticed. Once the blood product is ordered and the request for service is entered, then the lab will assign the blood product and the Blood Ready icon will appear. Once you document that the transfusion is started, then the icon goes away. Please make sure that you have signed up in Absorb for the new in-person PIVI competency. So there are dates in June and July and August and September. All the classes are going to be around 90 minutes and they're on the 8th floor of the foundation building. Again, this is a requirement and it's an in-person training. I think a lot of these are already full. So please, if you have not done this yet, go ahead and sign up for this now. To help prevent medication errors related to heparin drip administration, new brain tasks are going to be added every time a PTT is ordered to be drawn and associated with heparin protocol discontinuation to stop the infusion. So you'll see that now on your brain. This is a spoonful of sugar newsletter from our diabetes people about continuous glucose monitors versus our point of care blood glucose monitors that we have. So a continuous glucose monitor reads blood glucose from the interstitial fluid and displays the reading on a phone or a phone type device. And so why is this important for us? This means that there's typically a 15-minute delay from what the interstitial fluid glucose will read on the continuous glucose monitor and what a point of care finger stick blood glucose will read. So during times of rapid change in blood glucose, so when insulin is influencing blood glucose, the sorry, when insulin is influencing blood glucose, or they've just eaten, for example, there's going to be a larger discrepancy between the continuous glucose monitor and the finger stick. So we just need to keep that in mind. That we might not always be able to, in those moments, trust the continuous glucose monitor. We always have to do, according to our hospital policies, a finger stick for treatment purposes, which includes insulin calculation and hypoglycemia treatment. In the hospital, the continuous glucose monitor can typically remain in place unless they're going to 6C or for certain procedures, as long as the provider approves it. And then just remember that the point of care blood glucose has to be utilized for treatment decisions, regardless of whether they have a continuous glucose monitor or not. If a discrepancy is noted between the continuous glucose monitor and the point of care readings, just try to help the family understand that this is common, and that's really our first step in assuring them that best practices are being followed. If they continue to ask about the difference, feel free to call the diabetes educator, but help them understand that 15-minute delay between interstitial fluid and our point of care capillary tests. And then the continuous glucose monitor agreement will help outline hospital policy and expectations from the beginning of their stay to ensure consistent treatment throughout their current stay into their next hospitalization and across all patients. Going live June 24th, so here soon, is a new inpatient nutrition screening. So the language of the screening is going to be updated to reflect current evidence-based practice. So rather than the old vague screening, the new screening is going to be more specific. It'll ask more specific scripted questions with explanations for the healthcare providers under each question about why you're asking each question. So previously it was failure to thrive, yes or no, and it just said burn, yes or no, multiple food allergies, yes or no, infant formula 24 kilocalorie or greater, yes or no, ketogenic diet, yes or no. Now you can see over here on the right the new nutrition screening, a lot more easily understandable questions with explanations about why you're asking those questions. There's also new administration instructions for Tacro. We give a lot of Tacro up here. So keep in mind that if you're giving this via the feeding tube, so any sort of tube, you're going to have to flush with 15 milliliters of water before and then 15 milliliters of water after you give the Tacro. So 15 milliliters of water flush before and after any tube administration of Tacro. The Research Council is completing research on barriers to bedside handoff, so please take 5 to 10 minutes to take this survey to let them know about what barriers you all are facing when doing bedside handoff that make doing bedside handoff more challenging. A few other tidbits. Please make sure that we're utilizing PCAs to complete EKGs when they're available. I already talked about that, but make sure that we're doing that. PCAs, make sure that you have a Vocera when you're sitting. The CICU PCU unit collaborators are in full swing, so please make sure we utilize them when they're available. The second floor PPE room has officially moved to the 5 East Treatment Center. That code is 1234 star to the door. In preventing HIIs, make sure that we're initiating Contact Plus with the GI panel for patients with loose stool. Blood culture bottles are still on back order until July of this year. Effective April 10th, so this has already started, all staff need to perform a 30-second hand scrub before starting patient care on 7 West. So keep this in mind. It's a good practice always, but keep this in mind, especially if you're going to 7 West. As a helpful way to remember which blood products do and don't require a consent, so try to think of it this way. If a product's coming from pharmacy, so albumin, IVIG, factor, it does not require a consent because it's already been covered in the consent to treat that the families fill out on admission. But if a product's coming from blood bank, so packed red cells, platelets, FFP, cryo, granulocytes, it does need a blood consent. Our alarm settings on our monitors are as follows unless you individually change them at the bedside. So a yellow alarm at 90%, red alarm at 80%, and then if the patient returns to baseline within 20 seconds with a yellow alarm, the monitor is going to stop alarming. So keep that in mind. Starting in May, so it's already started again. I think you all know this by now. All the enteral feeding tube products stocked in Central Supply have a new ordering number via Epic. So please check with the unit enteral feeding binder. It's a purple binder for updated numbers before placing a new order for these patient-specific items. And then also, what started in May, they have started replacing our current box lunches with 3 healthy a la carte options. So they removed infrequently used items, and then they're working towards system-wide standardization with the Shasta soda products. Education. PCU, make sure that we have our monthly education done. June 28th is the due date. It's on 3-way communication safety strategy, on central lines, and tetralogy of flow. Here's the QR code if you still need to get that completed. And remember that to receive credit, you have to comment your name on the YouTube video. Important dates for the PCU. As a reminder, you have to complete the BLS portion for your BLS certification online in HealthStream before you attend the class. In the bottom left here are your 2025 BLS dates. Kind of the most important thing on the slide, if you register for a class and then you can't attend, you're going to need to withdraw from that class in LMS at least a week in advance to allow others to sign up. So if something comes up at the last minute and you need to withdraw, please do so at least 24 hours prior to the class and notify your leadership. But if you do not withdraw from a class or call or email one of us prior to the class, then you're going to receive TNA points. So keep that in mind moving forward with education. It's just a matter of respect for people so that there are open slots available. And then here on the bottom right are your PCU SIM dates. In case you haven't logged into the Absorb platform yet, the new LMS education platform, this is what it's going to look like. So when you log in, this is the page that you're going to see. When you click on My Courses, you'll be taken to a new screen that displays all your active courses, your current courses, and any future courses that you're going to take. Patient safety. So hand hygiene for 2025. We had a dip in May. So keep in mind that our greatest areas for opportunity are after patient contact and then after contact with the patient environment. Our biggest wins for April 2025 were 100% before procedure, 100% after blood or body fluid exposure, and then 100% before patient contact. Continued research shows that artificial nails and chip nail polish can harbor harmful bacteria even after hand washing, increasing the risk of healthcare-associated infections. Artificial nails, including gel, dip, and extenders, have components that interfere significantly with the efficacy of alcohol-based hand sanitizer. So even if proper technique is utilized to clean the hands, alcohol-based hand sanitizer does not officially remove microorganisms. Research also concludes that the hardening chemicals used in artificial nails allow microorganisms to be trapped within the nails upon painting and later when they grow out, permitting artificial nails to be a reservoir for continued growth of organisms. And then in a recent study, or a recent survey, it was identified that more than 1/3 of our direct patient caregivers have artificial nails, so 26 out of 67. And then 1 in 5 non-compliant individuals substituted gloves for hand hygiene in the last 3 months. That was at Norton Healthcare. So moreover, artificial nails harbor mostly gram-negative bacteria. And then analysis of our organisms identified in our hospital-associated infections from 2023 and 2024, again at Norton Healthcare, showed more than 53% were due to gram-negative organisms. So to clarify, the national average is like 30%, and we were at 53% due to gram-negative organisms. Again, gloves are not a substitute for proper hand washing, as they can develop microscopic tears, which introduce germs, and unwashed hands can lead to hand-to-glove cross-contamination. Hand hygiene must be performed before and after glove use. Our organization requires us to be 200% accountable for hand hygiene. So this means I'm responsible for my own accountability, and if I see others not doing the right thing, I'm compelled to speak up also. For hand hygiene, please ask others to wash their hands if you see them entering rooms without doing so or not performing hand hygiene in the rooms according to the 5 moments or not wearing appropriate PPE. Norton has a stand down policy that requires that when we're asked to wash our hands or put on PPE, we do so without arguing or responding negatively. If you have a difficult interaction regarding PPE or hand hygiene on our unit, please contact me or another A&M or Kristen as soon as possible. PIVs. Keep in mind that the best way to help our patients is to prevent PIVs entirely. So we have to utilize touch look compare when we're assessing peripheral IV sites, especially when they're infusing every hour. In order to touch, you have to physically go into the patient's room every hour. In order to look, you have to have the lights on when you're assessing. Turn a light on or use a flashlight every hour. And then in order to compare, you have to actually visualize bilateral extremities every hour. When we do find a PIVI, however, this is how you measure it. So it's X over Y times 100, X being the length of the noticeable swelling, and then Y being the length of the arm. So it's always the length of the arm. Even if the infiltrate's on the head or the leg or the foot, we always go by Y, meaning the length of the patient's arm from fingertip to armpit. What to do when we find a peripheral IV infiltrate or extravasation. So just an FYI, infiltration refers to leakage of a non-irritating vesicant solution, while extravasation is the leakage of a solution that can cause tissue damage. So we're going to stop the infusion, attempt to aspirate the fluids using a 1 or 3 ml syringe, assess the IV site, measure, elevate the extremity, note the amount and type of the infusion the patient received in the last 12 hours, and then we're going to stage it. So determine the stage based on the findings, and then activate the standing order set to order the appropriate interventions. Administer the appropriate antidote, so whether it was a red drug, a vasoactive drug, or a non-vasoactive drug will determine the type of medication you administer within an hour or less of recognition. And then make sure we're adding a wound assessment and monitoring the site accordingly. And then if it's moderate or severe stage, make sure we're notifying the wound team. Again, we don't have to notify the vascular access team anymore. They've got a lot on their plate, but we do have to notify wound team. CLABSI data. So this is our year-to-date CLABSI data for 7 East PCU. So we finally hit our goal of 90% bundle compliance rate in May. So we were 100% compliant for 50 out of 54 audits. This is huge, you all. You will notice, though, that we hadn't hit our goal any single month this year before that. So what can we do to keep hitting that 90% bundle compliance rate goal that we have? What are our greatest areas of opportunity? So zooming in on April and May, these were our deficits that kept us from hitting our 90% bundle compliance. So our dressings were not occlusive, needleless access devices were not timed and dated, CHG baths were not performed, and then an indication for the CVL continued need was not documented, and also our lines were not labeled correctly. In an effort to help increase our CLABSI bundle compliance rate, it's now required that the central line checklist that you see here be hanging on the IV pole at the bedside of every patient on 7 East PCU who has a central line. You'll notice that one side is a quick resource guide with frequently asked questions about our central line policies for the bedside nurse to use as needed. And then the other side is a central line checklist that's to be utilized every 12 hours during SBAR bedside handoff to ensure that we're adhering to every aspect of the CLABSI bundle to reduce the risk of central line infections. One nurse is going to read each bullet of the checklist while the other nurse visualizes the central line to ensure compliance. Any nonconformities are to be addressed immediately, and a safety report should be entered at that time. You may also have noticed that vascular access team nurses are rounding on central lines and that they'll be completing reliability checks on non-occlusive dressings. So these are the questions that they're going to be asking that you see here. Please keep in mind that this is not punitive when they come asking questions. It's not an attack on your nursing skill. It's simply a root cause analysis to determine what happened to allow for a central line dressing to become non-occlusive so that we can use informed strategy to mitigate those issues in the future. This is just a quick reminder. These listed metrics are what our diabetes team measures and where we want to focus our efforts when we're caring for our diabetic patients. So our education documentation, again, our goal is 100%. Pump site documentation, goal is greater than 90%. Insulin timing, goal is 100%. And then hypoglycemia, blood glucose recheck timing is greater than 71% as our goal. And then also remember that the 2025 diabetes review, which you have been auto-enrolled in, is required and it's due August 31st of this year. Here are some tips for placing a safety report. So how do you choose the correct safety event reporting form? So first, think through what happened as opposed to why it happened. So you want to choose the best safety event form that represents what happened and not try to categorize based on why it happened. So for example, medication error, incorrect diagnosis, delay in treatment, patient fall, pressure injury. Those are examples of what happened. Examples of why it happened would be miscommunication, human error, didn't adhere to a policy, knowledge deficit. So keep that in mind when you're putting in a PSR of making it about what happened, not why it happened. Here's a breakdown of our safety reports that have been placed on 7 East PCU year to date. So you can see that most of the time it's been related to diagnosis treatment category, 19% of them. So missed orders, delay in treatment caused by the nurse, delay in treatment caused by the doctor. And then also right up there is med errors. So most of those having to do with, at one point in time, not using one of the 5 rights. So there was a breakdown in using the 5 rights that resulted in a safety event. And then patient ID documentation. So patient ID bans. Last thing I'll mention here is this is a huge resurgence that we're seeing now. We had done a good job with it, but now, even today, I have only been here and it's only 2:00. And I've already put in 3 PSRs today alone for rooms that I've been in that have had patient armbands, not on the patient, on either the counter or on the computer keyboard. This is so unsafe. We can't do this. So PCAs, this is specifically for you all. Please do not lay patient armbands in the room on the counter or on the keyboard when we're getting a room ready. And the patient gets here and we take all the paperwork in. If you're going to take an armband in the room, place it on the patient. If they already have an armband, great. Don't just lay an extra one around. Make sure that our armbands are in the appropriate places. What is our single greatest opportunity to reduce patient harm events related to the PSR trends that we just saw? Here's a hint. It's the subject of our unit's 2025 PE plan and something that I never stop talking about. Bedside handoff. It's our greatest opportunity. Part of our 2025 performance excellence plan is bedside handoff, and we're also monitoring patient experience leader rounding and our patient experience scores. So for bedside handoff, though, let's focus on that first. Our goal is a 5% compliance improvement quarterly. Our Q1 baseline was 60% compliance, and our goal is just to increase by 5% compliance each quarter. In April, so the first month of Q2, our compliance rate for bedside handoff was 69% compliant. So 29 out of 42 audits were completely compliant. In May, we saw pretty much the exact same data. So we're having a difficult time breaking past this data point of only 29 to 30 audits compliant monthly. We need to be at 70% compliance by July to hit our goal of 5% compliance improvement quarterly. Please make sure that we are going to the bedside to complete handoff. So go into the room, pull up Epic, and give a full SBAR handoff. Every patient, every time. Also, when we're giving bedside handoff, make sure that we are completing our touch, look, and compare for our peripheral and central lines. Make sure that we're doing safety checks to ensure proper precautions are being followed. Make sure we're assessing family needs if they're awake. And please make sure we are wearing proper isolation and performing hand hygiene when going to the bedside. I know it might seem like an inconvenience to put on the gown or put on the gloves or the mask, but I promise that your health and safety, as well as that of your patients and families, are very much worth the mild inconvenience. These are our patient experience scores. So another thing that we're measuring for our PE plan for 2025. For May, both 7 East and PCU were in the 99th percentile. That's awesome. Year to date, our patient experience scores for the 7 East side are in the 99th percentile, which is amazing. And the PCU is in the 74th percentile. So last month we were in the 66th percentile. So we're getting way better than we were when we started off the year. We just started off really low due to first of all, due to low return volume, and then a few really heavy hitting negative survey results. But we are bouncing back because of the amazing care that you all are providing. So keep that up. Here are a few patient experience comments in the surveys. So they loved, they wished they would have had a dog to visit. We have multiple pets, and my child wanted her dog. Dog Heal would have been nice to have in this section of the hospital. The ED rooms could use some deep cleaning, but the staff was absolutely amazing this entire admission. The nursing staff being helpful and caring. Thank you very much for your hospitality. Thank you very much for your help. I'm very happy to be served by you. The departments seem like they have trouble communicating with each other, which made things take longer and cause confusion. There needs to be a clear communication about orders from doctors. We appreciate the care that my son received during his stay. The nurses and doctors seemed to care about my child and what was best for him. This next person didn't know of anything that could be done to improve their experience. And then lastly, they were very understanding. So mix of positive and negative, but I think it's good for you all to see what our patients are saying, their families are saying after they leave here. When we discuss patient experience, it is absolutely vital for you all to understand that you all are the eyes and ears of our unit. When you hear something about a patient or a family who has a negative experience on another unit or with non-nursing staff, so RT, radiology, doctors, JFK, we as your leaders need to know about it before they are discharged so that we can resolve the issues immediately with the appropriate people. You all are doing an amazing job of keeping us informed of negative patient experiences, so thank you for that. But our desire is to mitigate the effects of any unaddressed negative patient family experiences. And then sometimes, unfortunately, we don't find out about those issues until they fill out their patient experience survey after discharge. And then the things that we can do to resolve the issue at that point are significantly limited. So that is all I have for you this staff meeting. Thank you so much. I appreciate it.